Okay, we're going to get started, actually. I'm going to make a few quick announcements, and then we'll get this going. Housekeeping, just to let you know, there is a survey in front of you, so after Dr. Gandhi is done speaking, if you could please fill that out, and then just return it right on this table here, face down, would be fantastic, and that will help us tremendously. I'm Sue Gillerling. I'm the new Program and Outreach Coordinator at the Living Well Center, so I'm new and very glad to be here. And actually, we also have another new person, that's Angela McCrum. She is our new director of the facility here. So she's here tonight, and then our guest of honor. I'm gonna read this so I don't mess this up, but and I believe quite a few of you actually know Dr. Gandhi already, but Dr. Gandhi is the Director of Research and Education at the Northwestern Medicine Chicago Proton Center. Is that correct still? Yes, good, okay. And co-director of the Brain and Spine Tumor Center at the Northwestern Medicine Center in Warrenville. He remains faculty. He also retains faculty positions at Northwestern University Feinberg School of Medicine and at the University of Wisconsin School of Medicine and Public Health, where he remains engaged in research and teaching activities. Dr. Gandhi has also served as the National Principal Investigator of several multi-international clinical trials, and tonight he's going to be discussing recent developments in cancer therapeutics. At the end of the presentation tonight, just remember to turn in your surveys. That would be great. And last but not least, this is important, follow us on Facebook. If you haven't already, please do follow us on Facebook. It's Living Well CRC, and you can see our latest events and what's going on, and just keep in touch with us in more real time, but we'd love to have you following us. So with no further ado, thank you for coming.
Yeah,
yes.
No, thanks for having me. Good evening, everybody. Sorry I'm late. There's a lot of traffic on the road. I got late. I see a number of familiar faces. Thank you to my patients who are out here and joined us this evening. So I don't have a lot prepared, other than I'm excited that they asked me to speak about this topic because it's something I'm super passionate about, and that's the idea of doing clinical trials and how that impacts our oncology community. So I decided to kind of go through a number of questions. What, where, why, and how. I'll try to stay in order of clinical trials. But I missed one important question, and that's who. So who is it that we try to benefit with clinical trials? All of you. Mm-hmm. It's the patient that sits in front of us. It's their family members. It's their community. Quite honestly, it's the next person coming down the pipeline with the same diagnosis that you have. And so that becomes really important for us, that we provide the best possible care based on what we know we can do. Good to see you. How are you?
Oh, good.
Take a seat, please. Provide the best possible care for our patients. And so that becomes sort of the mantra behind why it's something that many of us are very passionate about. But when you are offered a clinical trial by one of your physicians or caretakers, there's so much that happens behind the scenes. And I wanted to talk a little bit about that so you guys have some knowledge of it. First of all, show of hands, how many here, who of you, have ever participated in a clinical trial? Okay. A couple of you, thank you for doing so. And so, the next natural question is, why do we have clinical trials? Well, from the WHO perspective, in terms of all of you, we seek to have options. So many of you have been diagnosed with some sort of cancer. Many of you have loved ones who have been diagnosed with cancer. And the clinical trials become an option. When we look at someone who has cancer, we have the conventional treatments that we know may or may not work. But with any type of cancer, including those that we can cure, as well as those we cannot cure, the more bullets we have in the barrel of our gun, the better it is. The greater our capacity to keep firing away at this darn little thing called cancer. Now, when a patient first comes in, the best bullet may not be a clinical trial, and that's okay. It may just be what we know works. And unfortunately with cancer, in some situations, some more likely than not, cancer can come back. So we need to turn the barrel and find the next bullet. Sometimes it's the same thing we used the last time. We do a little modification. So we fire away. And in some of those cases, the darn thing comes back. You turn the barrel again and have another bullet to use. At some point, unfortunately, in certain situations, we find ourselves running out of bullets. In our experience, the reason cancer patients are living longer, one of the reasons, than they ever did before, is number one, in some cases we're diagnosing them earlier than we ever did. But in other cases, it's because we keep packing the gun with more bullets. We keep having options to throw at this thing. See, the cancer is kind of like this.
Okay,
Hey there, come on in.
thank you.
You want some water, sir? It's kind of like this rather annoying bacteria or virus, in the sense that bacteria and bugs and viruses, they, the way they outgrow sort of whatever antibiotics we give them is they find ways to mutate. And when you have a cancer, it is a collection of a motley crew of cells. So here we are. We are a collection of people. We're all different. We have different shades of color. We have different backgrounds. Some are wearing hats. Especially some of those hats are Cubs hats. I know you wear. I'm a Brewer fan. Some have gray hair, some don't. But if we were suddenly in this pressure where they say, they suddenly closed this room and made this room tighter and tighter and tighter, some of us would find a way to get out. And that's the way cancer behaves, is that you put it under this pressure where you're using something to try to kill a whole bunch of cells, and over time some of those cancer cells can find a way to escape. So that's where the other bullets come in. So then we go after that cell that found a way to escape and say, okay, well, it didn't work when we tried this way. Well, let's try another way to get after it. And so that's the why of why we do clinical trials. To keep having bullets in the barrel of our gun, to keep firing at this cancer, so that you, the who, keep having options. And our goal, certainly within Northwestern medicine, is to make it feel like you always have an option for as long as you can tolerate those options. And so that's the why. Now there's a larger sort of component to why, and it's what we call the beneficence of clinical trials. Some of you may know, I personally was impacted at a very young age by someone who was very, very close to me, who was diagnosed with a brain tumor. And that's why I've since dedicated my life to researching brain tumors and doing trials and taking care of patients with brain tumors. But at that time, it was 20 plus years ago, we use what we know work, which is radiotherapy, which is what I do. But we also nowadays use a drug called Temodar, some of you have heard of this drug, for this particular brain tumor. And that drug wasn't around when my family member was diagnosed. In fact, it was developed maybe 5 or 10 years later. Of course, I didn't know any better. I was just a 16-year-old high school kid with pimples. I didn't know what this was or what my family member was going through. But it took a clinical trial of 300 or 400 patients Half of them got the drug, the other half who didn't. For us to learn that this could benefit someone. So one of the aspects of beneficence that patients take on as their responsibility when they go on clinical trials is that this intervention may or may not help them. It may cause harm, although we try to minimize that. We'll come back to that in a little bit. And it may be a situation where if you're on a randomized trial, you may not even get the intervention. But the knowledge that is gained from that intervention can have lasting effects. It can affect generations of cancer patients for a very, very long time. We all have our story. We all live our life. We all have our families and our loved ones. And then we're struck with this disease, either in our loved ones or in ourselves. And it becomes part of our story. And our ability to having a lasting significance to take that story and convert it into something that may be positive down the road for someone else is the aspect of beneficence, the why. Do we benefit the patient? Do we benefit future patients? And so that's the why of why to do clinical trials. So let's do the what. What is a clinical trial? So clinical trials are opportunities to test a new question. So many of you may have kids or grandkids and remember taking those kids or grandkids to their science fair. Ask a simple question. That's what clinical trials are. They're just an opportunity to ask a question, but how do you build that question? You build that question by trying to understand what is it that is the rationale and logic that makes this work? Why do I think this is going to work in a particular patient? So I'm going to, as I describe clinical trials, I'm going to talk to you about something that has been one of my foci of research that I've dedicated my last 10 years of my life to. And that is understanding how radiotherapy causes memory or cognitive effects in the patients we treat for their disease in their brain. And for several decades, we came to understand that radiotherapy, when we treat the brain, can cause some cognitive effects, whether it's the ability to remember something like this discussion, the ability to process complex things, to rapidly attend to something. We knew that was happening, but we also knew that radiotherapy is one of the most effective treatments for tumors in the brain. So how do we balance that, and why is this happening? So a couple decades ago, there was a young woman at that time, now she's a well-known attending at Stanford. Her name is Michelle Manji. She was doing an MD and a PhD degree. She was doing both. And as part of her PhD, super smart woman, she really wanted to understand this effect a little bit better. So she took a mouse model, took some mice, and she delivered radiation to the brain of those mice. And then a couple months later, those mice were sacrificed, and their brains were examined. And what she found was that radiation treatment led to a significant effect in a structure in the brain called the hippocampus. So the hippocampus is one of only two sites in the brain, the adult brain, that is constantly renewing itself. Most of the brain has fully developed nerves and neurons, the cells that make up nerves, that don't really do much other than do their activity. It's hard to replace them. But there are a couple spots, particularly two of them, one of them in the hippocampus, where you actually have a compartment of neural stem cells. There's a whole plethora of stem cells in this area that become new nerves throughout a human's life. So what is their function? So for many decades, I take that back, many decades ago, there was a young gentleman by the name of Mr. H.M. It's one of the most famous case studies ever published, one of the most cited case studies ever published, where at the age of 37, he had severe epilepsy, seizures, that were not controlled by any of the medications that were available at that time. So they isolated the seizure focus to be perhaps coming from his temporal lobes, where the hippocampus is located. So he had a very significant procedure done. His surgeons in Montreal removed both of the inside aspects of his temporal lobes. And in the process, they removed his hippocampus, both hippocampuses, they're on both sides. And it actually helped the seizure significantly. He survived till just a few years ago when he passed away. There's actually a very famous book written about him. It's a biography of his life. But from that, as soon as he woke up from that procedure, he couldn't remember any facts or events that happened from that procedure on for the rest of his life. He could remember a lot of things that happened before that procedure, where he was born, where his kids were born, where he was married, all that stuff. And after that procedure, he still could think very critically and could make decisions, but he couldn't remember. And suddenly, it became apparent to everybody that, this was in 1957, that perhaps the hippocampus is the center of our memory formation. And that led to decades worth of very intense neuroscience investigation that found that the hippocampus actually houses this compartment of neural stem cells. And those neural stem cells throughout a patient's life, throughout a human's life, are constantly renewing into new stem cells. So you never lose them. But, and when you develop a memory, one of those neural stem cells encodes the memory into a neuron. So as I'm speaking here, your neural stem cells are presumably encoding this memory into new neurons so that you remember it. Dr. Manji found was that in those mice that she had treated with radiotherapy, those neural stem cells couldn't become neurons. They didn't become neurons. Instead, they became scar tissue. Which is really interesting. So it suddenly said or suggested, well, are the cognitive effects of radiotherapy related to their impact on this neurostem cell compartment in the hippocampus? So there have been a number of studies that validated what she did in the mouse model. They tried to look at the mechanism as to why that was happening, and they found that it was an inflammatory situation, that when this neurostem cell compartment was exposed to radiation, it became super irritated and inflamed, and that inflammation process created scar tissue and caused those neurostem cells to, instead of becoming neurons, to become scar tissue. They were responding to their environment. Oh wait, it's really inflamed here. I guess we have to be scar tissue, not neurons. So, over a decade ago, our team, back then I was at the University of Wisconsin, we recognized, we saw this bulk of literature, and we said, well, can we isolate where these neurostem cells are in the brain? We can. It's in a compartment called the dentate gyrus. You can see it on an MRI. And then we said, well, can we use our advanced radiotherapy techniques to carve out that part of the brain, and thereby preserve those neurostem cells and preserve cognitive function? So that was our what. That was our question. We were asking a question: how do we test whether we can preserve the cognitive function of these patients. So we go from the what, that is our question, that is our hypothesis. We hypothesize that when we spare these memory zones, the neural stem cells will preserve cognitive function. Now, how do we show that? Well, one way is we could take a mouse and deliver brain radiation to that mouse and try to carve out the memory zones. It's kind of hard to do. These mice are super small. Their memory zones are only a couple millimeters. We don't have that advanced radiotherapy techniques to be able to do that. One team at University of California, Davis did something very interesting where they did the same experiment that Dr. Manji did. They delivered radiation to the brain of a mouse. And then in half of those mice, they had cultured, they had created neurostem cells in a petri dish. And they injected it back into the hippocampi of those mice after they had received radiation. And those mice that had that neurostem cells put back in after the insults of radiation, not only do those neurostem cells develop into new neurons, it reversed all the memory effects that the radiation caused. Interesting. Proof of principle. Can we really do that in a patient? So it became, how do we test this hypothesis? Well, we said, okay, well, we need to run a clinical trial. So that's what we did. So first things first, we did a number of, around that time when we were coming up with this hypothesis and saying, well, maybe we can make this work, several trials had come out, so a lot of data was coming out that when we treat patients who have brain metastases, that means their cancer in their body has spread to the brain, and we treat it with something called whole brain radiation. We treat the entire brain with radiotherapy. It can cause some memory effect. So we said, okay, well, here we have a model. Let's try this, see if it works. So we developed a clinical trial. It was actually one of my first clinical trials I ever wrote. And it was a very simple trial. It's called a phase 2 trial. And I'll come back to what that all means. But it was just, we took about 112 patients, and we said, okay, we're going to treat all of them with this technique where we treat the whole brain with radiation, but spare those memory zones, those neurostem cells. And let's see what happens. See how they do. We'll monitor their memory, see what happens. But thankfully, we had a lot of data to that point where we had treated patients with brain metastases with whole brain radiation and followed their memory. So we kind of knew how they already did, so we already had sort of this what we call comparison to something that happened previously. So we could say, okay, let's see how they do when we spare the memory zones and compare them to what we know happens. And then the next part of the how is, how do we run a trial? Well, we need volunteers. We need patients. And this is where clinical trials require collaboration. So the National Cancer Institute, many decades ago, recognized that when you run a clinical trial and you only run it through one institution, it takes a long time to recruit patients to that trial. In part because that institution only sees so many patients. That instead, we need to collaborate. We need to form cooperative teams that work together, what are called cooperative groups. So several cooperative groups were developed by the National Cancer Institute. One of them was a group that I work closely with. It used to be called RTOG, now called Energy Oncology. But at that time it was called the Radiation Therapy Oncology Group. They test questions on radiotherapy. And so this becomes a really nice opportunity because suddenly we have a trial of 112 patients. We can run it, at that time it was at the University of Wisconsin, we can run it at the University of Wisconsin, and it would take 4 or 5 years to fully complete that trial. Or we can be collaborative and cooperative and open it up to multiple institutions and to multiple patients all across the country. And so we did that. To do that, we had to get permission and approval from the National Cancer Institute. And I can tell you that is one of the hardest things to do in developing a clinical trial. The National Cancer Institute tries very hard to protect our patients. They're not going to take any random idea. It has to be fully fleshed out. So you have to submit, first step, a trial concept. 8 to 10 pages. I'm writing 2 or 3 of them right now. And you spend a ton of time, most of that time, just saying, why do I think this might work? Putting a lot of background. They're not going to just be willy-nilly about it. And then they take that concept and they give it to experts across the country who have a high threshold for it to pass. Because they have a high threshold because we are using taxpayer money to fund those trials. Each trial we run can run on the order of several $million to run. So that's all of our money that's being used to try to advance science. And so the majority of trial concepts that go to the NCI are actually disapproved. It's not uncommon. They're said, there's not enough science behind it, we don't like the way it was done, people offer their own opinions. So that's what we had to do first. Is we had to develop a trial concept that would be approved by the NCI. And thankfully, this idea was met with open arms. So we went through that first hoop. And then once we have that, then the NCI puts you on a clock. It's really stressful. They put you on a clock. They say you have 180 days to get this trial up and running and accrue your first patient. Because they know what happens. Once somebody gets something approved, okay, it's like, oh great, yay, we got it through, but I'm too busy to write it. So they put pressure on us as investigators. Get the job done. Get this out to patients so people have this. We think it's a good idea. We believe in you. And so that's what they do. So we developed a major protocol, and we ran it through RTOG, and we accrued that trial in less than a year. Accrued like gangbusters, faster than I would have ever anticipated. And that trial turned out to have very promising results. When we looked at the memory outcomes of these patients, and we compared it to the memory outcomes of patients who did not get the memory preserving or sparing technique, these memory outcomes were far better. So then it becomes, okay, well, is that enough evidence to say that this is the way it should be? Well, these patients, maybe we selected patients who were doing better overall, or who were better able to tolerate this, or who had less disease in the brain. So it doesn't become enough evidence to say this is the way, changes practice is the term we use. What changes practice is when we do a randomized trial. The idea being, we take that trial, take that idea, and we give half the patients the intervention and half the patients what we would otherwise do. And those patients are run in parallel. They are matched as closely as possible, so that at the end of the day in this trial, the only difference between the patients who got the intervention and the patients who didn't get the intervention is the intervention. Not because some patients had better likelihood of doing better or had better memory to start off with. It's matched perfectly. So the way to do that is something we call stratification. So we take these factors that we know predict for what we're trying to measure. And we say, okay, so for instance, in terms of monitoring memory, we know that the age of a patient makes a significant difference. Older patients have more memory issues than younger patients. And And so we stratify. So when a patient comes into a randomized trial, we ask them what is their age. They tell us their age. And then we put it into a computer with all the other factors. The computer randomly selects whether they get the intervention or not, but it's not that random. They look at all the other patients that have come on that trial, and they monitor how the age distribution is going. Because at the end of the day, they want both arms of the trial to have the same age distribution. So if you come onto a trial and suddenly you're somewhere along and maybe 30 patients are on one arm and 35 are on the other, and the 30 patients here are all older and all the 35 here are all younger just by chance, you are more likely to be randomized if you happen to be older into the younger ones because they want to balance it out. So that's how we balance the arms. So that's why we do the randomized trial, because so that at the end of the day we know, okay, these are the exact same patients, and if there's a difference, we can ascribe it and attribute it only to one thing, and that is the intervention. So that's what we did. We ran a phase 3 trial. Half the patients got the intervention, the other half did not. Now, one of the most critical aspects of clinical research is something called a data safety monitoring board. So this idea of safety is meant to protect the patients. The patients are volunteering to expose themselves to an intervention. We want to make sure that intervention is safe. We're testing whether it's effective, but first, is it safe? And a lot of this came out of some things that happened, unfortunately, in our world history decades ago. You may know some of this stuff. Stuff that happened during World War II and during the Holocaust. That Nazi Germany did on some of their imprisoned Jewish and other individuals, gypsies. And you may know about the Tuskegee syphilis experiment. African Americans were unfortunately exposed to syphilis just to see what happened. Unfortunate situations, extremely unfortunate situations, from which we learned a lot, but was never worth the price of that human being's life. So safety is highly emphasized. So how do we, as much as we can, ensure safety? Well, there are a number of mechanisms we do. So earlier I mentioned phase 2, phase 3. So what are these phases? There are various phases of taking an idea and testing it in a human patient. The first is called phase 0. A phase 0 study is what we call the first in human study. That we're taking this intervention, a drug, for instance. We've tried it on mice and monkeys and other preclinical models, but we need to see if it works in a human. So these are called first-in-human trials. These are obviously things that we have to be carefully regulated and watched, and oftentimes it doesn't involve patients. Sometimes it involves just normal humans. You want to volunteer for a study, we want to just try this out and see if you have any unusual reactions to it. But it can involve cancer patients, and usually we reserve it to be one of those last bullets in the barrel that we use. Because the patient's almost running out of options. Here's something we think might work. Let's try it. It's the first time using it. We'll carefully monitor. It may work. So that's phase 0. So something has to show that when it's first used in humans, it is safe, tolerable, does not cause undue harm. The next step is called phase 1 trial. A phase 1 trial is you say, okay, well, we've given this in a phase 0 at 10 milligrams, and people were fine. But is that sufficient dose to get an effect? We don't know. So what we'll do is we'll increase the dose slowly and see how far we can take it. So it's called a 3x3 design. First 3 patients on a phase 1 trial get 10 milligrams. And then they're followed for maybe 3-4 months. And they say, okay, those patients are doing okay. We're okay. All right, let's do the next 3 patients, 15 milligrams. Okay, let's follow them a few more months. They're doing okay. Okay, we're okay. And then let's go to 20 milligrams. Follow them. Oh, wait a minute. 2 of the 3 patients, blood counts just dropped. That's unsafe. And when that's unsafe, we say that's what's called a dose-limiting toxicity. That is limiting how much drug we can give. And the general rule of thumb is if 2 out of 3 get it, 67%, that's too high. If 1 out of 3 get it, then it's okay. Then let's try to go to 25. Let's see if we can do that. So when 2 out of 3 get it, as happened in this example at 20 milligrams, then we say that's too high, we go back down. And the maximum tolerated dose, this is our semantics, MTD, is 15 milligrams. We don't know if 15 milligrams works, but that's as much as these patients can tolerate. So let's take this dose and let's run a phase 2 trial. Well, a phase 2 trial typically is just like I described when I talked about the memory preserving strategy. I think we're out of seats.
Yeah, looks like they are.
Phase 2 trial is like I described. Okay, we're going to take about 100 patients, sort of kind of arbitrary number, and we're going to give them 15 milligrams of this dose that we said was the maximum tolerated dose. And let's see how they do. Well, we know that at a year, 50% of the patients' cancer comes back if we don't use this drug. We will consider this drug promising at 15 milligrams if we can get that rate up to 70%. So they run the trial. They do 100 patients, and they find that at 12 months, 75 of them are cancer-free. That's great. Was there something about these 100 patients that's a little unique and may not be related to the 15 milligrams we gave them? So then let's run the phase 3 trial. So that's how it works. But that process of doing first in human, phase 1, are meant to find the optimal dose, the maximally tolerated dose, before exposing it to many patients. And the phase 1s are also typically used in patients who are running out of bullets in their barrel. We want to give them a newer intervention. And we're just testing the dose. But we only do 3 at a time, so we don't want to expose them too long. So sometimes you will hear, if any of you ever get to that position, and I hope you don't, but if you do, that, sorry, the trial, or look, we got to get you on the trial now before the trial closes because we're about to hit our 3rd patient. Because they do it in bulk and quantities of 3. And so once they fill that 3rd patient, once they get that slot, trial's closed until they analyze that dose, make sure it's safe. So that's what's built up to it. But then on a phase 2 and a phase 3 trial, what do we do for safety? Well, that's where the Data Safety Monitoring Board comes in, or DSMB. During the course of a trial, and the reason why it's so important as physicians that if we want to do something outside the box, we do it on a trial, is that all of the sites that participate, all of the physicians, have to submit to the central organization that's running the trial any side effects that happen. Typically it's not the simple stuff like tiredness, but if someone has severe nausea or bone marrow counts drop quite a bit, radiotherapy, any injury that happens from radiation or a surgical trial, any injury from a surgery, any of that, everybody has to say, okay, we saw this, We're going to fill out a form, and we're going to submit it. And on that form, you describe what happened, when it happened, and you describe the severity. We have grades, grade 1 through 5. Did the patient need some sort of intervention to manage that? Or do they need to be hospitalized? And you execute your own clinical judgment as to the likelihood that that side effect was caused by the drug, by the treatment that you offer. In some cases, you don't know whether the patient got the intervention, like in a randomized trial, if it's blinded. You don't know, but do you think it might be related to what was done? And there are different ways to assess that. There's unrelated, possibly related, probably related, likely related. They have specific definitions. You give your best possible judgment. And when you have a trial of, say, 500, 600 patients being run across 100 different institutions all across the country, you avoid everybody's experience sort of biasing them one way or the other. Just because I see a side effect on one of my patients doesn't mean necessarily it's because of what the intervention was. It just so happened. But what happens is they collect all this data. So over the course of a trial, all these data are brought together. And typically twice a year, an independent committee of clinicians and statisticians will review all of the data. And they're the only ones, typically, in a blinded trial, who will know whether someone got the intervention or did not get the intervention. And they'll pool it all together. And they'll even look at it statistically. And if they find that the intervention that is being tested is unsafe up to that point, they have the power to shut down that trial. Because we do not want to expose our patients to excess risk. So that safety is super important. That in general, you will find that most clinicians would prefer to put a patient on a clinical trial than think outside the box, to have another bullet on a barrel, because of the innate protections of that trial for that patient population. As opposed to just saying, okay, I'm going to take this drug and give it to you, because it may or may not work, but I don't know, let's just try it. So that becomes such a critical component to participating in trials and protecting the patients we care for. So finishing off the how is we run through this trial, and at the end of it, we finish enrolling, or we finish recruiting, whatever. The trial that I ran had 500 plus patients. And then we stop it. Once we hit that number, we're done. And then we follow those patients. And we build in time points to say, okay, let's analyze the data. Is this working? So is this memory preserving technique actually preserving memory? It turned out, very fortunately, that it did, quite robustly, quite significantly. So then it is our responsibility, my responsibility as the PI of the study, to broadcast this to as many people as possible. And that's where we use our scientific meetings. We go out there, we submit abstracts, where we summarize the data. Those abstracts are reviewed by individuals who don't know anything about the particular trial, the innate aspect of the trial, and they'll say, this merits being put up there on stage and making sure everybody in our community hears about it. And then we get it out to patients as quickly as possible. So that's that component of it. But sometimes, in fact, more often than not, I think the number is 90% of promising phase 2 trials never end up holding their promise in the randomized phase 3 setting. That's why it's so important to do the phase 3. The majority of the time, the trial is negative. But there's more opportunity. So the National Cancer Institute really, and NIH really prioritizes using as much information as possible. So when patients enroll on a trial, or volunteer to be part of a trial, they're often asked to fill out a bunch of forms. Sometimes the forms say, will you allow us to draw blood from you and look at your blood? will you allow us to take any tumor tissue that we take from a surgery and collect it and analyze it? Most patients do. And the reason that's important is that information becomes incredibly valuable to ask the next question. So for instance, right now, I'm relatively sleepless because I'm in the middle of writing a $1 million grant to do exactly that. So this memory preserving technique that we tested it in 3 trials with a total of 1,000 patients. And we're so fortunate that those patients volunteered their blood, volunteered to let us take their MRIs that we did. We have this treasure chest, tremendous information that we're asking the NCI to give us money to look at all of that, to evaluate biomarkers in the blood or biomarkers on the imaging studies, to see how does that help us determine who is more likely to have memory issues and less likely to have memory issues, and who may actually benefit the most from and the least from this memory preserving technique. So that's the next step of the how, is the ability to take this information, positive or negative trial, and translate it into something bigger than that. So one of the areas of tremendous excitement that where the trial mechanism has really paid off is in the area of immunotherapy. You guys heard of immunotherapy? Mm-hmm. So immunotherapy is the idea that the cancer in our bodies is truly a foreign entity to that body. So as a foreign entity, it should be attacked by the immune system, no different than a virus or a bacteria or anything like that. But the cancer has found a way to shield itself from the immune system and put on a mask that makes it look like it's part of the normal body. So the immune system says, oh, okay, you're one of us. We'll keep going. This immunotherapy drugs have revolutionized some areas of cancer, lung cancer, melanoma, are the most common, where what happens is we give a drug that specifically takes that shield and rips it apart. It takes the shield off the cancer so that it can't hide anymore from the immune system. And when it does that, that immune system can go after that cancer. So that's tremendously exciting, and to be honest with you, it is very much significantly impacted what we do. As an example, melanoma used to be one of the most difficult cancers for us to treat, and has now become one of the best cancers for us to treat. Not that there's a good cancer to have, but patients are doing so much better now with immunotherapy than they ever did before. And that is because that melanoma really liked to shield itself with that shield. Another example is lung cancer, that we found that patients who have a high expression of a particular shield called PD-L1, when we attack that PD-L1, at 5 years, 30% of those patients are still living and doing well. That was never seen before. So tremendous opportunities there. And that was all developed through the phase 0, phase 1, phase 2, phase 3 trials that have completely changed how we practice. So that's a good example. So I'm going to finish with where. How am I doing on time? So where? So this is something that I'm particularly passionate about. That is, I do a lot of research, but I practice in what we call community-based cancer centers. So CDH, Delnor, Proton Center. And we're part of Northwestern as a whole, but it's been my mantra, something we really try to emphasize, especially in the western suburbs, CDH, Delnor, and Kishwaukee, that we want to bring clinical trials to these communities. Historically, especially in Chicago, these trials, especially the ones that give a lot of bullets in the barrel, were largely limited to centers that are far away from communities like Geneva. Oftentimes downtown, Northwestern, downtown, University of Chicago, Rush. I have to go downtown tomorrow morning for brain tumor board, and I'm not looking forward to driving through that traffic. And we know that patients, with their lives on the line, are willing to do anything and everything to make it work, to give themselves another bullet in the barrel. But we as clinicians need to recognize that I call it financial toxicity. Time and effort and money it takes for a patient to travel somewhere should not be required to participate in clinical trials. It is our job to make these trials available as broadly as possible. The trials that I did with the memory preserving technique were available everywhere. They were not only available everywhere, the reason they were so important that they were available everywhere is because, number one, those trials accrued like gangbusters. Over 25 patients a month went on those trials. Number two, in the process of those trials, we taught other radiation oncologists all across the country our techniques that we developed to preserve the memory. So that if the trial was positive, those patients didn't need to come to me to get that technique, even though I developed it. They can get it anywhere, because all these people have been trained. So it was immediately impactful in the larger community of cancer. Hundreds of thousands of patients who present with brain metastases. And so these trials that we develop, we want to avail as broadly as possible. But there are some limiting factors. When we run like a phase 1 trial, it's a very detailed assessment of how that drug goes throughout the body. We call it pharmacokinetics. So the patient gets an IV, gets the drug infused, and we watch for toxicity and side effects, but then 5 hours later, we draw blood to see how the drug is distributing. 10 hours later, we draw blood. And it's very intensive. It's meant to be safe, but to better understand that drug and how it distributes. That's not possible in most community-based centers, like Delmar cannot support a phase 1 trial. That's okay. Those are small trials. There are only 9 patients on those trials. But more advanced trials, phase 2, phase 3 trials, are important to make available to this community. So the patients don't have to drive all the way into the city or wherever, sometimes out of the city and out of the state to get access to them. So that is another area where the National Cancer Institute has made it a priority. They recognize that the majority of cancer patients are actually managed in the community places like Delmar or CDH, not in major academic centers. So it's important that we avail these options to everybody. And so that is what our mantra has been, is that we built an infrastructure. I started here about 7 or 8 years ago, and at that time, between CDH, Delmar, and Kishwaukee, we enrolled less than 5 patients a year on any clinical trial. This past year, I think we hit 100, and our numbers keep rising because we've really emphasized availing options to patients and making sure they felt like they can access it closer to home. And this is a generosity of our institution. So to run a research trial, you need research associates, clinical research associates called CRAs, who have to monitor those patients. They create a whole separate chart on those patients. They check every box, dot every T, cross every T, dot every I, to make sure everything's done properly. In fact, I sometimes tell my patients that while I will take care of you the same way, whether you're on a trial or off a trial, I can tell you you're going to be followed much more closely because I'm going to have a whole extra person following you when you're on a trial. Because we're going to be watching you very carefully. That takes money. Our research office from CDH Delmar to Kishwaukee is $1 million budget per year. And it needs to get larger. So the clinical trial organizations reimburse us to run these clinical trials. They say, okay, look, we know it takes time and effort and resources. We're going to give you as It's money for every patient you enroll on a trial. The problem is, I don't know if you know, but the NIH is not funded very well. And the National Cancer Institute is not funded very well. And as a result, there's only limited amounts they give us. In fact, for a patient who enrolls on a trial from the National Cancer Institute, we as a research office lose money because the cost of support to monitor that patient is less than what we receive from the NCI. Thankfully, we have pharmaceutical companies who are very well funded, and so they give us a lot more money, and so we find a balance there. I gotta give Northwestern, CDH Delnor, and Kishwaukee a ton of credit because they are essentially taking it out of their own revenue to support our research office. That's a very unique situation. And that is the reason why some of other hospitals in the suburbs don't have a robust trial infrastructure or a portfolio. Because the hospital needs to spend that money and they just don't have it, or it's not a priority for them. So you can imagine the how of this is so tricky and so challenging, but it always ends up coming down to the who, the patients. We feel very strongly that clinical trials are a critical component of taking care of our cancer patients. Giving them more barrels, more bullets in the barrel, giving them more options, making them feel like they can get the best possible care closest to their home, and so that we can service the next generation of cancer patients that come through these doors. I'm going to stop there, and I'm happy to address any and all questions you guys may have. But thanks for coming. Nice audience.
Thank you. I've got a few questions, and some of them are related. I'm assuming, based on what you said, Dr. Gandhi, that there's a lot more clinical trials for cancer specifically than there were 5, 10 years ago. All right? I assume that's a fair assumption. Does that mean that FDA approval for the procedure or the therapy or the drug is about the same, longer or shorter than it was, say, 4 or 5 years ago?
It's a phenomenal question, and I'm glad you brought it up because as I was wrapping up the presentation, I said, oh wait, I forgot to talk about the FDA. Well, maybe someone will ask a question about it, so thanks for bringing that up. Perfectly timed. So, first of all, to your original point, no, it's not necessarily true that 5 or 10 years ago we had more trials than we have now, or we have less trials than we have now. I would say that is the case compared to 20 years ago. Ever since the early 90s, when the NIH was starting to get significantly funded, we were getting much more money to do a lot of clinical trials. So we've had an explosion of opportunities since then. And pharmaceutical companies were also kind of given a lot of opportunities. Depending on the disease site, it fluctuates, and it has to do with the science of things. So for one type of tumor that I researched called a glioblastoma, we're going through a fluctuation right now, where we actually have a couple new trials coming down the pipeline in a few years, but the last couple of years we've had very few trials. It just depends on the science. The funding is always there, but that also depends on politics. That sometimes the NCI has a lot of money, and sometimes it does. Back in the 90s, it had a ton of money. About 5 years ago, they significantly cut funding for clinical trials. It didn't necessarily time with about the time of the recession. It didn't necessarily, was not necessarily caused by the recession. It was more politics. So the FDA. So the FDA is the Federal Drug Administration, and it's an important aspect of what we do with clinical trials. So FDA has two major compartments to it. One is related to drugs, and the other is related to devices. And the governance of both is vastly different. So I'll speak with devices first, because that falls under my purview. With devices, the FDA requires only one thing, that we demonstrate that that device is safe. Doesn't need to be effective, it's just safe. So what are devices? Well, surgical robot we use to take out a prostate, as an example. We don't need to show that the robot is effective, we just need to show that it's safe. Radiotherapy, proton therapy. FDA approved. We just need to show that it's safe, which it is. We don't necessarily need to show that it is more effective. Now that is changing, I can tell you actively changing, but what's already been grandfathered in is continuing. In drugs, FDA requires safety and effectiveness over what is already standard. And that's where they emphasize the clinical trial. They have to be done. And so that becomes a challenge, especially for cancer patients. Because we're talking about bullets in the barrel, when we're down to our last couple bullets, a cancer patient naturally will say, I want more options. I want more bullets. Well, we have this drug, but it's in a phase 1 and it's not open right now. Or, there's something else there, but we don't have a trial to put you on. Or you got to travel all the way to Houston or Rochester or downtown Chicago to get it. So that's where there's a lot of pressure right now on the FDA. In the prior administration, not to go too much into politics, but in the prior administration, there was a reluctance to let go of that because they really emphasized safety. They did not want to expose patients off of a trial to drugs that weren't even shown to be safe. In the current administration, that is a lot of pressure to relax that. So one of the ways that they developed in the last administration to relax it is something called breakthrough designation. So a drug is run in a early phase trial, phase 1 or phase 2. Doesn't even get to a randomized trial, a phase 3. And it shows that it's safe, but it shows so much promise that why do we need to wait another couple years for the phase 3? Let's give it breakthrough designation. Let's allow patients access to this because, holy smokes, this looks really impressive. So they have to apply to the FDA. They go through this huge sort of, it's almost like going through a clinical trial. It's almost like going through a court trial because they really analyze and they bring patients. There's a lot of lobbying that goes on. But a good example is Avastin, or bevacizumab, which is a drug that was used in breast cancer. Many years ago, that was run in patients who had metastatic breast cancer, and in a couple trials showed tremendous promise and safety. So they granted it breakthrough designation. But contingent on the ongoing phase 3 trial to see what the final results were in a randomized where patients are balanced and the only difference is some got the drug and the others didn't. And so a lot of patients jumped on, the pharmaceutical company made a lot of money, and then the phase 3 trials were negative. It showed that the patients who got the drug were comparable to the patients who didn't, at normal factors, but their timeline was no different than this. So they withdrew the FDA approval for metastatic breast cancer. The drug company, who at that time was Genentech or Roche, I forget what it was. The Roche ended up buying Genentech, I forget when it happened, but their stock price dropped. It was a huge change. But again, it goes back to, okay, where's that balance between giving patients options and giving them another bullet, giving them another shot at this, but not causing harm? We don't know. Right now, there's a lot of pressure to relax that even further. And if something's even as early as a phase 1 or very early phase 2, to let a patient have the opportunity to make their own decision to have access to that drug. It's an ethical question that I think all of us will have our own opinions on.
But you spent a lot of time talking about safety, the safety protocols that you follow. And question is, do the drug companies follow the same protocols as the universities, medical centers, and research centers like we do operate out of?
They have to, because they're under FDA jurisdiction. So I've designed a few trials for pharmaceutical companies. I can tell you the rigor with which you have to design those is very high. The FDA, if they find something wrong, and it's a silly mistake, they'll shut it down or they won't give it the FDA approval. You can imagine that's hundreds of millions of dollars of investor money that is lost in a situation like that. So the FDA keeps a very, very high, tight regulatory situation. I'll give you an example. One of my friends down at WashU, so I do radiotherapy, and one of the things we can do is deliver something called radiosurgery, which is high-dose radiation to an area. And this idea came about maybe 10, 15 years ago, that could we give high-dose radiation to the heart for patients who have arrhythmias of the heart. I remember this because my program director at that time told me, "Hey, Vinay, what do you think of this idea?" And I said, his name was Deepak. I said, "Deepak, that is the dumbest idea I've ever heard in my entire life." So, "You sure you don't want to work on it?" "No, I don't want to work on it. I'm going to work on this memory preserving thing. I'm not going to waste my time with it." Turned out it works magnificently. Talk about putting a foot in your mouth. So they published in New England Journal last year, my buddy who took this and made it something, that it works really well. It actually cures these people of refractory arrhythmias. It's completely revolutionizing the field. But they did that only at WashU. So their proposal now is they want to do a multi-institution trial to validate it. And the FDA is saying, they're saying, look, radiotherapy is FDA approved. We use it for a lot of things. The FDA is saying, no. You're using it for the heart, for an arrhythmia. It does not count. So if you want to run the trial, you got to run it under our auspices, guidance, and oversight. So they are detailing, so we're going to participate in the trial, so that's how I know. They're detailing every little minutia of how that trial is run, because they want to guarantee that it is safe for patients, as an example. Does that address your question? Hey, Bill. Yeah.
You mentioned tests using mice, and then you alluded to one with monkeys. I'm wondering, in the medical profession, I never hear about cats or dogs being used in these tests. Is there a prohibition, or, because to me, those are really, smart animals. And are they used?
Yeah, they are. It's a really good question. They are. It's a matter of cost. So you can imagine to house 100 mice in a facility is not very expensive. To house 100 dogs can get extremely expensive. And the dogs themselves, you can breed mice for pretty inexpensively. It's hard to breed dogs to some extent homogeneously. That gets very expensive. So lab researchers, I'm not a lab researcher, the lab researchers do this, sort of say, okay, I want to test this question. I'm only given this much money by the NIH. Do I run this experiment in a preclinical model, we call it an animal model, the money will only pay for 10 dogs, or in 50 mice? I'm going to pick the 50 mice, because I can find more about it. The second is resources. There are some places that are better situated, that have better veterinary departments to run large animal experiments. We call them large animal versus small animal. So my old institution, University of Wisconsin, has one of the top veterinary schools in the country, and actually has a facility, veterinary oncology, where they actually give radiotherapy for dogs who develop cancers, just to help them. So that facility actually has the capacity to run experiments on dogs, and that's one thing they do, but that requires a tremendous amount of resources to do large animal type research. Yeah.
With the collaboration with CDH and Northwestern, do you have the same choices for the clinical trials, or would you be better off going to Northwestern?
So, it's a good question. It's a work in progress. So we were fortunate that before CDH Delmore and Kishwaukee became part of Northwestern, we had already developed our clinical research infrastructure and our office, and we're enrolling quite a few patients and availing a lot of trials. Now we're collaborating with Northwestern. We're trying to find mechanisms to avail trials that we have. For instance, we have a lot of trials at the Proton Center, but we don't do protons in downtown Northwestern. So how do we allow those patients to have access to that? And vice versa. The patients, the trials that they have down now, they tend to have more drug trials, but most of those are phase 1 trials. We can't do that. We just don't have the infrastructure for it. But is there a way we can bring those patients out? And so our ultimate goal, and we're working on this, is that we become one Northwestern as it comes to clinical research. And the reason that becomes very useful, and that these trials are accessible in various parts of the system, the reason that becomes very useful is that then when we go to a pharmaceutical company and we say, look, invest in us, avail the trial at our place. And guess what? You not only just have Northwestern Memorial, you have CDH Delmore, Kishwaukee, Lake Forest, maybe Integra. You have a tremendous population from which we can recruit patients, and that's attractive to them. The rate limiting step we face is more of a mechanical issue. It's something called the IRB. I don't really go into the IRB. The IRB is the Institutional Review Board. Every institution has its own IRB that regulates research. So whenever we want to do any research, either a clinical trial or something as simple as, okay, I want to look at 10 charts of patients that I've treated this way, see how they did. We have to ask the IRB for permission. An IRB that we use, we already had implemented it. That's part of our hospital system. The IRB downtown is part of the university, Northwestern University, which is a tremendously bureaucratic institution. So those are the mechanics we're trying to figure out. But our ultimate goal is, yes, we want to avail everything across both campuses, all campuses. Yes, ma'am.
Yeah, I got like a 2-part question. One is, the person's been great for a year, and you've checked and you've watched them. A, can they continue on this medication that hasn't really been approved? Or B, if they stop and it comes back with a vengeance, how do you know? How long do you keep an eye on these patients?
Yeah, it's a really good question. So generally, most clinical trials involve a drug therapy. We generally keep the drug therapy on until what we call progression, where the cancer grows. Now, you're right, there are some situations where there's a finite amount of time, in part because the anticipated timeline of when that cancer will grow may be well down the road. And really, in the phase 1, phase 2s, we've only tested it for 12 months. We don't know what happens afterwards. So the general principle is whatever you've tested and established to be safe, that's what you use. And in some cases, it's till the time of progression. Now, there are scenarios, as you described, where a patient is say, okay, well, it's going to be a 12-month period that you're going to get this investigational therapy, and after that, you can't do it anymore. And then I have seen scenarios where cancer was doing great on it and then suddenly decides to rear its ugly head. In those situations, it is possible to do something called compassionate use. This requires a couple things. Number one, appealing to the pharmaceutical company, because they essentially just gave the drug to the institution and to the patient for free for 12 months. Appealing to them to say, look, we know you gave this to us for 12 months. Can you give it to us for free for longer? Because so-and-so did great on it for 12 months, and we stopped it because that's the way the trial was, and cancer grew again. It's compassionate use. And most pharmaceutical companies are actually compassionate, and they understand that. They want to service the patients as best they can. But it's some of that becomes a financial decision on their part. But then there's the other part, the regulatory, the safety. So in addition to doing that, you also have to appeal to the IRB, Institutional Review Board in an institution. Say, we would like to offer this to this patient as a compassionate use for the same reasons. Will you allow us to do it? We're doing it off trial, but we will do it under your guidance and still monitor things with the pharmaceutical company. It can happen. It's not a guaranteed situation. Tricky situation. The way sometimes it doesn't become guaranteed and sometimes it doesn't work out is that the pharmaceutical company says we just don't have the resources. In which case then we appeal to the insurance company and the insurance company says, no way, I'm not going to pay for that, it's too expensive. That's usually the most common situation I've seen. Most times the IRB is willing to be open-minded. But also that process could take weeks to months, right? A lot of advocacy of the clinicians who are already busy to begin with. Does that address your question? Good question. Other questions?
Immunotherapy.
Yep.
You mentioned that there's been success with lung cancer and with melanoma, and I didn't realize about melanoma. I also understand that it hasn't been uniformly successful, so it's been more successful in some cancers than others. Just kind of comment on that and how that's all looking.
Yeah, so it's a really good question. So it turns out each cancer has its own shield that it uses. And the immunotherapy drugs we've been testing thus far target a particular shield called PD-L1 or PD-1. There are two different shields. And the drugs we've created are specific for those shields. Turns out, for the most part, cancers that use a lot of that PD-L1 shield, that have a lot of that around them, respond the best to those drugs, to those immunotherapy agents. But a lot of other cancers have other shields they use. And so that becomes, so in the process, so we've established proof of principle that, hey, look, if you remove the shield, you can get after that cancer. But now we need to figure out better other drugs to look at these other shields. How do we get those off? And not all cancers hide themselves with the same shield. So the lung cancer, for example, I showed you, the lung cancers that tend to respond best to that immunotherapy, the ones where 90% or higher of that shield is PD-L1. Those who don't have that shield, or who have less than 50%, don't respond as well. And so there's a certain degree of heterogeneity there. The second thing that we come to appreciate, at least in the brain, where I focus, is that oftentimes in the brain we use something called steroids. Steroids help calm down swelling. Some of you are my patients, and I've been on steroids before. And so the steroids actually suppress the immune system. Right? So why do we use steroids, particularly in the brain? We use steroids because this thing in the brain, this lesion is causing a lot of inflammation and swelling. We want to calm the inflammation down, and so we're using steroids to do that. Well, the way we use immunotherapy to kill cancer cells is to cause inflammation. So if we use steroids in those situations, then we are counteracting the effect of immunotherapy. So what we've faced as a challenge in brain tumors is the balance between giving steroids because we need to, because the tumor is causing a lot of inflammation, and because the patient's having symptoms, versus how that impacts the effectiveness of that immunotherapy, of the immune system. Does that address your question, Paul? Sorry, you had a question.
I take Ibrance and letrozole for metastatic breast cancer. And a while back there was a study that used surgery and radiation. And my doctor said, well, hey, it takes a long time to get studies going. Maybe the study was set up before Ibrance, and he kind of was leaning towards stick with Ibrance. And I was like, is that common or likely that maybe a study is set up, and then while it's being set up and approved and everything, another therapy comes along that's better?
Yeah, no, it's a really, really, really good question. So when we run trials and we design trials and lead trials, we have to somewhat think ahead. So, for instance, next week I'm proposing 3 trials at our energy meeting, and I'm proposing those trials. I'm thinking, how will this field change by the time, if we get this trial solved, through all these hoops, by the time this trial finishes? And some of that you can guess, and some of that you can't, but you have to prepare. So, okay, well, there's another trial going on. What happens if that trial is positive? How will that affect this trial? Or this other trial is going on. What happens if that trial is positive? How will that affect this trial? So, but sometimes you can't, and unexpected good things happen, which is a drug shows positive results, it's helping patients, and you never put that into the trial. So we have 2 options. If you're early enough in the trial, you can stop the trial and say, well, hold on a second, we got these new practice-changing findings, and Ibrance needs to be part of this trial. Well, if we're going to put the Ibrance in, now we got to recalculate our statistics and our sample size, and then we have to restart all over again, and then go back to the NCI and say, please, please, please give us more money. That's harder than it seems to do. Or the second option, which sometimes happens, and it's probably what happened in the case you're alluding to, is that the trial is nearly finished, or essentially just finished, or already finished, and it comes out at the same time, and how do you interpret that? And to be honest with you, that's a hard thing to interpret. Usually we leave that up to clinicians, thought leaders, to help put things in context. Do we think that this would be worthwhile in a new setting? So I'm going to use the immunotherapy as a great example. Or you know what, I'm going to use the area of research that I've done, which is this idea of whole brain radiotherapy. So a decade ago, when treating brain lesions, we found that when we treated with whole brain radiation relative to just radiosurgery, which is just treating each lesion, patients had more memory issues. Now 10 years later, we've developed 2 interventions to prevent those memory issues. So all of that data, just throw it out the window. So now we need to reinvent it. We reinvented the wheel, now we need to retest it. How does this compare? How do we use both of these interventions? So it's good, it keeps things exciting for those of us in clinical research, and it keeps things moving forward for our patients. But sometimes it's not as black and white as we hope it is, in part because of the timing of how things come out. Does that address your question?
I think so.
Good questions. Other questions?
In a clinical trial, if I had an illness, I would want to make sure that I got whatever was going to be used to correct that illness. But it usually seems you have this or you have a placebo. You notice when you ask that several people had been in these trials, what their response was and which category they were in and how that works. Because, I mean, I understand the explanation, but to me that's kind of a con for the lay person who has an illness and wants to get some help. You don't know, do you, when you're in these trials, whether you're actually going to get that help?
Well, I had the clinical trial I was in. I got the drug, the trial drug, and
Did you know it at the time?
yes,
Oh.
because it was well, every patient knew what, whether they were getting it or not. And then for the second trial that I was going to do, oh, by the way, that drug worked for me for 1.5 years. And then they had closed the trial and they stopped it. And, because it was only working for about 5 of us in the whole world for that sort of thing. But some of the side effects are really treacherous. But anyway, then they asked me to do a second clinical trial. Well, I was just about done going downtown all the time for it. And so when they told me that I wasn't going to get the drug, I said, okay, bye. You have that choice.
So you bring up a number of really important points that I want to emphasize, and I'm sorry I didn't. Number one, participation in clinical trials, you just mentioned, is completely voluntary. That when you sign your name on the dotted line to say, I'm volunteering to do this, that is not binding. At any point in the trial, you can come off of it, including at the time that you find out whether you get the drug or not. You can say, I don't want to do this. The second point is this idea of blinding. So sometimes it's possible to blind a patient and their physician to what that drug is or intervention is, and sometimes it's not. So in the case of the research that I do, sometimes we do some research who some get protons, some get conventional radiotherapy. You know whether you're getting protons because you're going to the proton center. I know you're getting protons. So, but in most cases we try to blind. And you're right, patients don't know in those situations. But at the time, if the cancer grows, then you are allowed to unblind that patient. Break the seal, that's what it's called. And cross over. So if the patient got the placebo and you find that out, then you can appeal to the insurance company and say, look, you just gave us this drug for all these patients. Thank you, by the way. Can you give it to this other person who was on the wrong side of this? And most of the time they say yes. In fact, part of the reason they say yes is they want to learn what happens to those patients who were on placebo and then crossed over. The third thing, and I'll get back to the third thing that you mentioned that is super important, is that more often than not, I mentioned trials are negative. But when they're negative, it means that the overall patient population, as an average, was not benefited. But there are a small cohort of patients that are benefited. Every trial has a small cohort. They have a tail. And what's so important about trials that I know is huge burden for patients, especially when they have to go all the way downtown, is all the ancillary stuff that they have to do. Blood draws, scans, all the extra testing. It can be very burdensome. But that information is what really helps us understand why your 5 was different than the other 45. And what was it unique about those 5 patients that allowed them to benefit and get a year and a half. And that, even if the trial is negative, that is the most important piece of information we could ever understand looking more forward down the road. Sorry, you were going to add something.
Well, that's okay. One thing that I was told, though, they don't do placebos. They never call it placebo, so when you're in a clinical trial, you're getting some kind of medicine. You're not just getting a sugar pill or anything like that. You are getting some treatment.
Sorry, thank you. So let me mention that. So why would anybody want to be on a placebo arm? Well, at the end of the day, the placebo arm is actually what we call a control arm. The control arm is what we would treat you if we did not have the trial. So we're giving patients a treatment. We're just giving them the treatment we would give them if we didn't have the trial. But then there's this 50% chance you may get something in addition to what we would otherwise give you. Does that make sense? Sorry to make that clear. So you're getting standard treatment, but you have a 50% chance of getting something better, maybe, or something more harmful. We don't know.
I never understood that. Thank you.
Sorry for not clarifying. It's a good question.
Could you say something about precision medicine? Because I kind of raised a flag for me when she said that 5 people benefited from the trial, but a lot didn't. Are they looking back now with precision medicine, 2 trials where only a small subgroup benefited to see if maybe they had some particular characteristic or something that would make that be like a precision medicine for them?
Yeah, so it's exactly, you're absolutely right. So when I said that all that extra testing that patients have to do, it's very burdensome. That's our attempt to try to understand what is it about certain patients that do respond versus those patients who don't respond. What is it about their tumor, themselves, their genetics, that allows them to get a differential response, positive or negative. And then we use that information to then say, okay, let's try something different down the road. Rather than taking this bullet and shooting at every cancer patient or every cancer out there, well, it turns out these cancers with this mutation, those are the ones you want to shoot that bullet at.
So the patients that benefit from the trial could still go on and get the medicine or not? If they decide not to, that it wasn't beneficial enough people didn't benefit from it, what are they going to do about the people that did benefit from it?
So there are two situations where a trial is closed while a patient's getting a drug. So actually, we had an example of this very recently. So there's a trial of patients with something called glioblastoma, giving them an immunotherapy directed towards a drug called a protein called EGFR. And there's so much promise to this. We were super excited about it. And we found out maybe about a month or two ago that they did an early analysis. The trial had only recruited maybe about half the patients thus far, but they had built in like this early analysis as to, okay, is this really working? Not just is it safe, but is it working? And they found that there was no benefit whatsoever. That even if they continued to recruit the back half of the patients, statistically, there was no way this intervention could work.
And I'm referring to this particular situation where 5 people benefited from it.
Right.
So what happens to those 5 people?
Right. So there were some patients who could have benefited from it, like their tumor hadn't grown again. So what do we do in that situation? So the drug company, it was AbbVie, said, number one, you need to call every single patient right now and tell them these results. And number two, it is up to them. If they want to keep doing the drug, we'll give it. If they don't, that's their choice. But they have to be informed as soon as possible. So we picked up the phone, we called every one of them, and they made their choices.
But then if the company says, if the pharmaceutical company says, how many times do they say no? It's too expensive, it's too costly for that small amount of people.
I think it's, it really depends on the scenario. Everybody's very different. So this was a case of a 600-700 patient trial, huge trial. I mean, the drug was already created.
Oh, okay.
It's not like, they already had stockpiles of drug ready for the other half of these patients. So, okay, well, we'll ship it to them if they want it. What are we going to do with this? We're not going to use it again.
So with the small trials, they have
Small trials are a little more challenging because they have limited drugs that they've created for the trial, and that adds a little bit more nuance.
And do you have to go to these drug companies and say, can you make this product for me? Or that one, in other words, you're going to add it in?
So when you have a compassionate use situation, usually the company's not going to make the product. They check if they have it in store, and you ask, can we use it for this patient?
Gotcha.
And to be honest with you, a lot of that is relationships. So those of us who do a lot of research and try to avail clinical trials to patients, we spend a lot of time massaging relationships with these pharmaceutical companies and their representatives. We are super OCD about making sure that all the data we collect is rigorous, done, timely submitted, so they respect what we do and we're helping them, so that when we need help for our patients, they do the same thing in return. And if they don't, then we get really upset and say, well, we're never going to enroll patients in your trials again. So they know that that goes both ways, two-way street. I think we've exceeded our time. I appreciate everybody coming. Thank you so much. Happy to address questions afterward. Thanks, guys.